Welcome, everyone. This is Dr. Sharon Adler from the California Prevention Training Center, and thank you so much for joining us today for our STD Expert webinar series. Today's webinar will be on sexual history taking, and I'm thrilled that Yvonne Piper from the San Francisco City STD Clinic is here to share her expertise with us.
Hello, Sharon, and hello, all attendees.
First, I'd like to take a moment to introduce our program. The California Prevention Training Center is a national training center that delivers innovative training and capacity building assistance to public and private healthcare providers alike. We are funded by the CDC to provide collaborative services for a wide array of medical, health promotion, and community professionals serving persons and communities impacted by STDs and HIV. Please visit our website to learn about our trainings, clinical precepting, and technical assistance for implementing practice improvements in your clinical setting. We are part of a national online STD clinical consult service, www.stdccn.org, and you can log on to email us a clinical consult. These consults are answered within 1 to 5 working days, depending on urgency. In terms of our upcoming STD Expert webinar series, we have our spring schedule coming out soon for 2019. The next webinar will be on vaginitis, and check our website. And if you're already on our listserv, you'll probably get an announcement about it. You can also contact Dominique Remenick if you have any questions. But the next one will be in the spring, and it will be on vaginitis. So hopefully you'll be able to join us for that one as well. We have a social media presence. You can find us on Facebook and Twitter. And we definitely want to hear you, and so I'm going to review the interactive features of the webinar format. First, I want to highlight, and some folks have had questions about this already, on the right lower side of your screen, there are links to resources, as well as the slides from today's presentation. When the speakers are presenting, you may not be able to see these links, but we'll definitely bring them back up at the end of the webinar. At the bottom, underneath the slides, are the questions and chat box. Many of you have already been utilizing this. Please feel to participate. And this is where you're going to input questions. There will be a formal Q&A at the end of the presentation, so you can input questions at any time during the webinar. And we have over 500 people registered, and it looks like there's about 333 people right on the phone right now. Also during the webinar, there will be a couple of times that we're going to ask you to respond to a poll, and a poll just came up right now to ask folks how many people are listening to this webinar at your site today. So if you can just take a moment and put in how many people you're sitting with at your computer, because often there's more than one person, and that gives us an idea of the actual number of participants. So we'll just take a moment to do the poll. And then we can close that poll in just a moment. Okay. In terms of disclosures, all speakers, trainers, and planners of this webinar have no conflicts of interest or relevant financial relationships. Regarding continuing medical education credits or nursing credits, if you'd like to have these, this webinar is approved for 1 hour of CME or CEU. And I'm going to go through the process of what you're going to need to do next. So after the webinar, you'll be sent an evaluation from the National Network of Prevention Training Centers. Please fill this out. This is what you need to fill out to be able to obtain CMEs or CEUs. And these are all free. We also really encourage folks who don't need CMEs or CEUs to also fill out the evaluation, because this is really useful to us. This is how we can get feedback from our participants. If you haven't registered, again, there's this late registration resource link on the bottom right of your screen. Any questions? Again, Dominique Remenick is a great resource for you. And now it gives me great pleasure to more formally introduce our speaker for today, Yvonne Piper. Yvonne Piper is a nurse practitioner at the San Francisco City Clinic, the municipal STD clinic in San Francisco City and County Health Department. She is also faculty for us at the California Prevention Training Center. She received her nursing degree from the UCSF School of Nursing. Her main area of interests are STDs, family planning, transgender health, and precepting of clinical trainees. And outside of her clinical time, you can find her volunteering as a trainer for the San Francisco Sex Information or at the gym preparing for her next powerlifting competition. Go, Yvonne. So I'm going to turn the
Thank
webinar
you.
over to you right now.
All right, sounds good. Thank you so much, Sharon. So welcome to our webinar on sexual history taking. As Sharon mentioned, I don't have any disclosures at this point. Let's review our objectives here. This is what I hope you'll be able to get out of our webinar today. And I'd like to start off with a poll for you folks. And I'm wondering how often you take a sexual history on your patients. Choices are listed there. Okay, yeah, let's go ahead and close the poll. So it looks like the majority of folks are getting sexual histories pretty regularly, whether that is every visit or when it's indicated by your patient's concern. But then there's some other folks who are maybe not getting it as often, so hopefully after this webinar you feel comfortable getting sexual histories more regularly on your patients. Thanks, Dominique. Let's go ahead and close. So why would we want to take a sexual history? A few different reasons. To know if our patients are at risk for STDs or HIV, unplanned pregnancy, or any other issue related to their sexual health and practices. It can help us inform our testing for STDs or pregnancy, as well as other interventions for prevention, such as PEP, PrEP, or vaccines. We want to know who to screen for asymptomatic infections. If someone does present with symptoms, it helps us to broaden our differential diagnosis. Preventing serious sequelae, for example, undiagnosed chlamydia that could develop into PID and later infertility. Helping to help us assist in contraception, family planning, and in general informing our risk reduction conversations with patients. Although we know it's important, a lot of us do have concerns about taking the sexual history. For example, confidentiality. Maybe you don't have a room or a setting where you can take these questions in a really confidential manner. Maybe other people could overhear. I know that some clinicians are concerned that the information a patient gives might not be accurate or truthful. It might not actually reflect the patient's practices. Some of us don't know what to ask or exactly how to ask it. There's some time constraints. We've got a lot of things we need to cover in a visit, particularly if you're in a primary care setting. And is it really so important? Think of the other competing priorities that our patients are presenting with. What if your patient reports something that you don't feel equipped to handle, such as risky behavior, intimate partner violence? Do you have the resources to be able to refer your patient? And then some of us might have discomfort with a particular patient or population. This could be due to differences in age, gender, sexual orientation, or some other factors between provider and patient. Patients also have concerns about sexual history taking. For patient concerns around confidentiality, things I've heard are, will this be put into my chart? Are you going to tell my insurance what I've told you? And will my partner or my parents, who I share a plan with, find out about this and they read my file? Some patients are just not comfortable discussing their sexual practices with anyone, and this could be not only medical providers, but also with their sexual partners. Sometimes patients aren't sure about the impact their sexual practices have on their overall health, so they might not see the relevance of us asking these questions. There can be issues with stigma. For example, a patient who has a difference between their declared sexual orientation and their behavior, they might not feel comfortable disclosing their practices to you. And also patients can have a lot of shame around their sexual practices. This might be internalized shame that they have from their own perception of their behavior, or it could be they've had a negative encounter with a provider in the past who shamed them for their sexual practices. And once again, it's similar to how we might feel uncomfortable. A patient might have discomfort if they are of a different gender or age or sexual orientation than their medical provider is. A few of our barriers to taking sexual history, and I will go into these in a little bit more depth. As providers, we might not be comfortable discussing sexual issues, and a thing I want to reiterate throughout this talk is all of us have judgments and biases, so it's important for us to be aware of them to be able to not put them on our patients. There might be weird dynamics between a patient and provider, or an uncomfortable dynamic. The ones that I'd mentioned earlier, age, gender, and sexual orientation are some big ones. Some providers aren't necessarily familiar with the content of a sexual history or the language to use, and a lot of us don't get very adequate training on this. I'll review a couple of studies that show this. And overall, is STD prevention a priority in your practice? Patients present with lots of other health needs, so if you're in a primary care setting, sexual health might not be the first priority for either you or your patient. And what if your patient has other psychosocial issues that are competing for resources and time? For example, if your patient has a situation with homelessness, if they want help with smoking cessation or other substances, sexual history often is left for the very end. So another poll that I would like is when we think about patient characteristics that could make us uncomfortable when discussing sex, what are some things that come up for you? So I'm very encouraged by the number of people who say they're always comfortable discussing sex. This is fantastic. Okay, so that looks like a pretty good selection of answers. Let's go ahead and close the poll, Dominique. All right, so overall it seems like people are pretty comfortable discussing sex, although age, gender, sexual orientation, substance use, and health literacy did get quite a few votes as well. Okay, let's go ahead and close. So when we think about discomfort with sex as a barrier, a quote that I love, which is from The Hidden Epidemic, is it may require greater intimacy to discuss sex than to actually engage in it. Your patients might not be particularly excited about discussing sex with you, but this doesn't mean that they are not having sex. In terms of how comfortable clinical trainees are with taking a sexual history, there was a survey about 10 years ago asking medical students in both the United States and Canada about their comfort with a sexual history. And a little more than half of the respondents felt like their training on sexual history taking was not adequate. So about half of us feel like we're not getting the skills from our programs to be able to do this activity. And even though a lot of folks felt like they weren't adequately trained, the majority were comfortable asking about sexual concerns. So it's not necessarily a match between lack of training and comfort in approaching the question. In terms of providers who are currently in practice and their comfort in taking sexual history, another survey was done from primary care providers across a selection of specialties. Once again, about half felt like they were adequately trained in the topic of sexual history taking, but the majority felt comfortable in doing it despite what they perceived as a lack of training. Now, those are the numbers that they report the comfort level with, but in terms of the actual practice and how often they were asking, folks aren't asking all of the time. So majority of folks ask about sexual history when it's relevant to your patient's chief complaint. A little more than half ask if patients are having sex, but a very small number of the providers polled were actually asking about multiple components of a sexual history. We'll go into the components a little later in this webinar, but overall folks might ask, but they may not go into a lot of detail. Overall, patients would really like for us to be taking their sexual histories. There was a survey done of gynecology and urogynecology patients, and patients overwhelmingly said they wanted their provider to take a sexual history. For this poll, respondents under the age of 40 were more excited about doing a sexual history than folks over the age of 40. But overall, patients did not report feeling embarrassed to discuss sex with their providers. And they noted that overall primary care providers tended to ask about sexual history less often than gynecology providers did. So a few tips for us. Sometimes patients want to bring up the topic of sex themselves. And so if they do bring it up, by all means, we should follow that. But even if a patient hasn't brought it up, that doesn't mean they're not wanting to discuss it. So it does help our patients if we can initiate the conversation about sex. Another barrier that we had noted is sexual orientation. So sometimes providers feel like having a patient with a different sexual orientation can make the topic of sex more challenging to discuss. Once again, this was a survey, and they looked at not only students, but residents and fellows at one U.S. institution. They specifically were asking about their knowledge, comfort, and training on sexual history taking in lesbian, gay, bisexual, transgender, and queer or questioning patients. And there was definitely a correlation between the provider's reported comfort with the sexual history and discussing safer sex practices or management of sexual issues. So the more comfortable someone is, the more they're likely to discuss the prevention methods around sexual health. About 20% of people reported they had no training at all in sexual history specific to LGBTQ patients. And so the big take-home point is a lot of providers want more training in this area specifically. Maybe you got sexual history taking when you were a trainee, but it wasn't necessarily focused on this population. Gender can also be a big barrier. There was a survey done of physicians, and they were asking about factors that made them comfortable or not in taking a patient's sexual history. And generally, when providers and patients are of different genders, that tends to be something that provokes more discomfort. So male physicians in this survey reported being more uncomfortable in taking the sexual history of a female patient, and conversely, female physicians were less comfortable taking sexual histories of their male patients. When the provider and patient genders were congruent, they reported that they were more comfortable, but still not 100% comfortable. But overall, we do know that gender can be a big barrier to taking sexual history. Age as well tends to be a barrier. This is from that same survey I cited on the previous slides. Providers reported that they were less comfortable taking a sexual history on a patient under 18 or over 65. However, we do know that youth, 15 to 24-year-olds, account for about half of new STDs, so taking sexual history on younger patients is absolutely imperative. There can be some socioeconomic variables that also can present barriers to sexual history taking. And a couple of things I found in the literature were when a patient has educational attainment below the college level, some providers felt less comfortable. And the other thing was homelessness. One study that was done in a clinic that was primarily serving patients experiencing homelessness showed absolutely no sexual history taking of homeless patients. And once again, this is not because they're not having sex. This tends to be there could be discomfort or there can be competing priorities. But even if a patient has a lot of other issues going on in the psychosocial realm, I would certainly recommend continuing to get a good sexual history to make sure that you're identifying other risks. So in terms of who's at heightened risk for STDs, things that we know, young people, and the numbers that we had cited by the CDC said under 24, we could take that up to 35, but generally younger folks are at higher risk. We know that people of color are disproportionately affected by infections in the United States. People using certain substances might be at heightened risk. That can be injecting substances or other substances through any route, for example, methamphetamines. Transgender folks can also be at higher risk for STDs, and this is a population that hasn't been extensively studied, but we definitely know from the available data they're at heightened risk. There tend to be higher rates of people living in or being in correctional facilities, men who have sex with men. If someone was exposed to an STD, chances are higher that they could contract it, as well as a history of other STDs may predict future STDs as well. And then in terms of sexual practices, here's some of the things that we would want to look at. And unless we get a comprehensive sexual history, a patient may not volunteer that information. So really these are things to be asking our patients so we can identify who might be at risk. Overall, sexual health is an important part of people's overall health. Sexuality is a part of a lot of people's lives, and it's something that they would like to be able to continue in a healthy fashion. And if we make sexual history taking a more routine assessment, it normalizes sexual behavior and discussing sex for our patients. If you bring up the topic and they don't identify a problem, you're setting the tone for them to be able to come to you in the future if problems do arise. We want to destigmatize sexual behaviors by building trust with our patients and discussing sex as well as other topics during our clinical encounters. And if we find opportunities to discuss risk reduction, this is a great way to segue into those conversations. Also, sexual history could be relevant in a few other concerns. For example, if someone is seeing you around concerns about fertility, definitely would want to know about past history of STDs. Someone who's experiencing sexual dysfunction, once again, sexual history would be very relevant. And in diabetes and cardiovascular disease, we can also want to get sexual history that will help us to figure out what's going on for our patients. So how do we approach the sexual history? Here are a few pointers for us in getting a good history. So the thing that I recommend everyone start with is knowing your own areas where you might experience judgment or bias or discomfort. Is this with discussing particular sexual practices? Are there specific patients or populations of patients that you feel uncomfortable discussing sex with? If you're not familiar with a topic that a patient brings up, like a particular sexual practice, does it make you uncomfortable? And if so, are you able to ask your patient to clarify? We want to discourage you assuming what something means. If you've got any doubts, certainly ask your patient, that's not a practice I'm familiar with, could you tell me what that entails? I do want to make it clear, every one of us has judgments, and the most important part is knowing what they are so you can withhold them instead of putting them on your patient. We want to have a non-judgmental approach, but this does not mean that we personally are free of judgments entirely. We've all got them, and it's just important to be able to work with our patients, and that means withholding judgments. A few of the guiding principles of sexual history taking. There's a great article from 2013 called Standard Operating Procedures of Sexual History Taking, and the main points that they had in here were making the process patient-centered, using it to inform evidence-based diagnostic and treatment interventions, and having a unified approach for all patients, regardless of age, gender, sexual orientation. And also CDC's 2015 STD guidelines recommends we have effective counseling skills, and that includes a non-judgmental approach, having compassion and respect for our patients. So this is my #1 clinical pearl with sexual history taking, and this seems a little counterintuitive, but I highly recommend you don't start with the sexual history. Try to get some other parts of the patient's history out of the way first. So that might be going through past medical history, medications, allergies, and once you've established a little bit of rapport, then you can talk about sexual history. I especially think this is important if it's your patient's first visit with you or if the patient is clearly uncomfortable discussing sex. So getting a little bit of the other medical history out of the way and then letting them know, okay, we'll now start talking about sexual practices. That's how I like to approach this topic. And certainly some patients will be more comfortable than others. If your patient starts out volunteering information about their sexual history, you can follow their lead. But for folks you don't know as well or who are uncomfortable, this is the approach I like to take. So when you are introducing the sexual history, here's a few pointers to keep in mind. I'd recommend doing this in a private setting, and what that means for my clinical setting is we ask that there be no friends, partners, or family members in the room with the patient. Sometimes a family member or friend came to serve as a translator. Ideally, you should use an unrelated translator if you can, and that might be calling a language line to get a telephonic interpreter. Doing this in a private room, not where other patients could overhear the conversation. So if you're in, for example, an emergency room and you kind of have a bay where multiple patients are being interviewed for history, try to get sexual history in a more private setting if possible. And I like to acknowledge that these are personal questions and that we appreciate that they might feel uncomfortable, but we're asking these to be able to best serve them. Emphasizing that the information is confidential and letting them know you're not going to disclose this to other people such as insurance or partners. Stressing how sexual health issues are related to sexual behaviors so that way they know there's a rationale for why you're asking this. And explaining how the information is going to help you care for the patient. So we're not asking this just out of prurient interest, we're asking this so we can really know how to best help you. And I also like to normalize this, and I tell the patient we ask everybody who comes here the same set of questions, so that way they don't feel like they're being targeted with sexual history questions. In terms of how to open the question, there's a few different ways that you could approach this. So some people do like to use very broad and open-ended questions. A few examples of that would be, is there anything about the topic of sex you'd like to discuss with me? Or what concerns about sex would you like to talk about? So this lets the patient really jump in with their own questions or concerns. Some questions might be a little too broad for patients, and they might not know examples of how to answer that. So that tends to be one potential disadvantage of these very open-ended questions. For some situations, it can be more helpful if you narrow the questions and make them a little more directed at particular aspects of the sexual history. For example, introducing it by saying, I'm going to ask you some questions about your sexual history and practices. We ask all patients who come to the clinic some questions about their sexual practices. And you might start by asking a general question such as, have you had sex in the last whatever interval of time you're interested in? Maybe that's 3 months, maybe that's a year. So these ones are a little less patient-centered in that they're kind of a more yes or no, or giving you a specific answer to your question sort of format. But for folks who maybe are hesitant to start the conversation themselves, this can be an effective approach. In terms of when to take a sexual history, there's really not a ton of guidelines that exist. Some recommendations I found in the literature were at all new patient encounters, so that way you can know if this is a new patient to you or your practice, maybe they will need more frequent sexual history taking. Definitely when their presenting concern could be related to sex. For example, genitourinary symptoms, the patient requests screening for STDs or HIV, they'd like to discuss contraception, sexual dysfunction, or incontinence. And then anytime a patient brings up a sexual concern or the topic of sex, that's a great opportunity for you to follow their lead and get a more comprehensive sexual history. And then how often should we do this? Would this be every visit or only some visits? And I certainly think this depends on your practice setting. I'm in an STD clinic, so this is what we do. We ask everybody at every single visit. If you're in a primary care practice, I would recommend at minimum asking your patients annually, if not more often. If you're seeing someone for a follow-up visit and the original visit was related to sexual health, the key question I like to ask is, since your last visit here, have you had sex? If so, that's your cue to get a little bit more comprehensive history, such as, was it with a new partner or a partner you've had before, and what kinds of practices did you engage in? But if someone says, no, I have not had sex since my last visit, you know that you can do a much more abbreviated sexual history. So what are the main components we want to get out of a routine sexual history? The mnemonic device I'd like to introduce is the 5 Ps, which is partners, practices, past STDs, prevention of STDs and HIV, and pregnancy history and plans. And the CDC's 2015 treatment guidelines has a really nice handout. I've got a link at the end for you if you want a little bit more depth on this. So as we're fleshing out each of those Ps, what are the things we would want to get? So when we're discussing partners, we want to know in someone's lifetime who their sexual partners have been, and then in the last, say, 3 months or a year, who have your partners been. And if they know, a good question to ask is, have any of your partners in the past year had sex with someone else while having sex with you? So your patient might be monogamous, but we don't know if their partner is. So that could be your cue to get some screening. Asking them about their specific sexual practices, such as what types of sex do you have? This would mean oral sex, vaginal sex, anal sex, or use of sex toys. Asking them about what STDs they have had in the past, if any, and how do they prevent STD or HIV transmission. So this is a great opportunity to discuss vaccines such as hepatitis B and HPV, seeing if they are a candidate for PEP or PrEP. Do they use condoms if they have sexual practices that would indicate condom use, or monogamy, or otherwise selecting their partners. Asking them about their last HIV test and seeing if there's related risk. They might not themselves have sexual risks for HIV, but they might have other risks such as injection drug use or a partner who's an injection drug user. It's also a good time to ask them if they engage in commercial sex work or use other substances. And then if they do use condoms, getting an idea of when and how often. Some people will report condom use 100% of the time. Other folks might use condoms with some partners but not others. So this is a good time to get a little more detail on that. And then for folks who might be planning a pregnancy in the future, asking them if they've had children before, are they planning a pregnancy? And the key question is, would you like to be pregnant within the next year? And this can help you to inform if they want to contracept in the meantime or not. And then asking them what, if anything, do they do to prevent pregnancy, and are they happy with their current method? Okay, a few more communication skills to put in your toolbox. So open-ended questions as much as you possibly can. Leading questions or yes-no questions definitely don't let the patient talk as much. So trying to give them the opportunity to do the majority of the talking. So ways to start those questions would be who, what, when, where, and how, or just a more open, tell me about times you use condoms. Tell me about how you discuss testing with partners. Encouraging your patients to talk if needed. Some patients have no problem talking. They can do that just fine, but others need a little more encouragement. So encouraging them to say it in their own words, or maybe giving a range of behavior and asking the patient for their experience, such as, how often do you use condoms? 50% of the time, 100% of the time, never. Using active listening cues to urge your patient on, it shows that you're listening and you're interested. So good eye contact, nodding, and telling them to go ahead. And then nonverbal communication goes a long way. Watching your body language, making sure it looks open, avoiding frowning or other faces, trying not to show surprise or shock, even if that's how you feel, and practicing looking positive but also neutral in your facial expressions and your posture. A little more on the open versus closed end of questions. The open ones that are going to allow your patient more freedom to direct that conversation and take it in their own direction, they sometimes do take more time. So if you're limited in time in your clinical encounter, you might not use open-ended questions all the time. Closed ones might be more time efficient, but sometimes the patient's experience of that is not that you're being efficient, but that you're rushing them or being impatient. However, I do love the more closed yes-no questions if a patient's really reluctant to talk. If they don't want to describe their practices in great detail, giving them an example and seeing if they can say yes or no, and then maybe they'll feel more comfortable discussing it more. But in general, any way that you can get a sexual history is better than not getting it. One open-ended question that I would actually recommend being cautious with is a why question. Sometimes why sounds like you're demanding them to explain their behavior. So this might come across as more judgmental. So in terms of your open-ended choices, that would be my least favorite of those choices. A few things about your language selection. We're trying to sound kind of neutral. We want to be interested, but we don't want to seem like we're directing the conversation or judging the patient. So as I mentioned earlier, why questions might come across as judgmental. Think of how these statements sound. Why didn't you use condoms? Or why didn't you finish your medicine? That can seem a little off-putting to a patient. They might feel like they're being accused of something. Using gendered terms makes assumptions. So being careful with terms like husband, wife, or boyfriend, girlfriend, trying to use terms such as partner or spouse, or if a patient does tell you the gender of their partner, making sure that you follow that. And in general, anything that sounds value-laden, like you're putting your own values on the patient, such as, I think you should do this, or I really want you to do this. That definitely lets the patient know you've got an agenda, and if they don't agree with your agenda, they might be reluctant to tell you that. Things that can be more useful are encouraging your patient to tell you more. So tell me about this time. Or if a patient does come in and you feel that urge to use a why question, trying to rephrase it, such as, help me understand. So if a patient comes back and says, I didn't finish my medication, instead of you asking them why, just telling them, you can tell me a story about this. So what were some things that happened that prevented it? Or help me understand how I can support you in taking that in the future. Letting them know that you're listening and you're here for them, but you're not trying to shut them down or put your agenda on them. Overall, you want to sound positive, so you want to sound encouraging and supportive, but also neutral. So if you do have an agenda or a judgment, trying to keep it in check. And definitely don't make assumptions about our patients. So this could be about their partners, whether that's gender of partners or number of partners. Don't assume that your patients are monogamous, even if they're in a relationship. Asking about specific sexual practices and not assuming what patients engage in. So being very clear that we want to talk about all of the different kinds of sex they might be having. As we mentioned earlier, a lot of providers say they specifically want more training in LGBT health. The Fenway Institute has some really great online modules. I've got a link here. So if you'd like to build your capacity in serving those communities, I would highly recommend taking a look at what Fenway has. Silence can be a really powerful tool in the exam room, and us being able to listen and allow the patient room to speak is very powerful. So practicing our listening skills, and in general, when doing sexual history, we'd like the patient to do the bulk of the talking. So make sure that they're talking more than you are. Practicing being silent, giving yourself a pause before you speak to see if the patient has more talking to do. And sometimes using repetition can be helpful. So you might repeat the patient's last word or phrase just to see if they have more to say about that. In terms of vocabulary choices, we want to be clear with patients. So this means avoiding medical jargon, especially if it seems like the patient's health literacy might not be at a level where they could understand it, and clarifying terms or stories when necessary. So I'd mentioned earlier, if a patient mentions a sexual practice that you're not familiar with, maybe asking them to clarify for you what they mean by that. And then following or mirroring your patient's language. So this might be the term they use for their partner. Are they saying partner or are they saying boyfriend? Their sexual practices, use their terms as much as you can, and follow their language when it comes to the reason they've come in. So if they're saying that they want STI testing, follow that and say STI. Or if they're coming in for birth control and they want that term used instead of contraception, follow their lead on that. And one great catch-all phrase to make sure that you have addressed your patient's concerns at the very end, asking them, is there anything else about your sexual practices that I need to know to ensure your good health care? And they might not have anything else to mention to you, but if they do, this is a great opportunity for them to say, yeah, we didn't discuss this, but I'd really like to mention it to you. What if you run into time constraints or there's an issue that you touched on but you didn't fully address it? If at all possible, schedule a follow-up visit and say, this is a great conversation, I'd like to pause it for now. Can we continue this in a visit in 2 weeks? Referring them to a counselor if need be. So if you've got someone available in the clinic and the patient disclosed some behavior that they want to discuss further with somebody, you might want to link them to somebody else. So if you've got a therapist or a social worker, that might be a great resource. Patient education handouts are always really helpful. So if there's something that you brought up but you couldn't go into depth on, certainly refer them to a handout or another care resource, website, support group, something else that can help to fill in the gaps where maybe your training can't do it or your time constraints just don't permit you to fully engage with that. So in terms of wrapping up, this is certainly a great time to implement your new skills. So be willing to give this a try, and you're going to find as you practice this, there's going to be certain phrases or approaches that work for you in your practice in your clinical setting. So this is not a one-size-fits-all approach. There's lots of different ways that you can take a sexual history, and these are just a few pointers here. My biggest thing that I can recommend for folks is work on recognizing what your biases or judgments are and learn to keep them in check. We all have judgments, and it's really important to be aware of what yours are so that way you can be sure you're not putting them on patients, you're acknowledging them, and keeping them to yourself. Talk less and listen more. Have your patient do most of the work with sexual history taking. They should be telling you a lot more stuff than you're asking. And if they have trouble, you can certainly go to those yes or no questions, but overall, open-ended questions, trying to get them to do most of the talking. Asking sexual history more often. So that might be every visit, or it might be slightly less often, but generally trying to ask more often than you don't ask. And then using those 5 Ps to guide the conversation. Here's a few resources for you folks. So CDC's 2015 STD treatment guidelines are excellent in terms of the ways that you would treat and test for STDs. They've also got a really great app for both Apple and Android devices, and they do have a whole pamphlet that is about STD sexual history taking. So I would recommend looking at that one if you want a little bit more detail about the 5 Ps. I've got links to the California Prevention Training Center here, and a couple of other organizations, especially if you want more training in LGBT health. Health Professionals Advancing LGBTQ Equality, it used to be known as GLAMA. They're a really fabulous resource, and then those Fenway Institute modules I mentioned earlier are also on here. Once again, LGBT health education, taking routine histories of sexual health can be helpful. And then if you're specifically interested in transgender health, I'd recommend the UCSF Center of Excellence for Transgender Health. Okay, we're going to have some time for questions.
So thank you so much, Yvonne, for that really informative, wonderful presentation. And yes, we do have time for questions, and people are putting questions in right now. I'm going to start with one of the first questions that we got. Wondering whether you have any tips on taking a sexual history if the patient reports past sexual abuse, if they're reluctant to talk about the abuse, or even current sexual practices.
Yeah, that can certainly be a hard one. If they mention it or you're somehow aware of it, I would certainly recommend just checking to see if they feel safe right now. If they're not feeling safe, following that lead and talking about a safety plan or resources for them. If they're not willing to discuss it at that point, what I would do is thank them for their willingness to disclose it to me and let them know we don't have to continue this conversation right now, but at a future visit I'd be open to it. So for that person, you might not get a lot of sexual history. So I think with this one, it's a matter of establishing rapport and letting them know that you're open to that conversation in the future.
Another couple questions, people have asked questions about any tips for talking with youth. Particularly,
in terms of youth, oh, sorry, Sharon, I cut you off there.
That's okay, particularly LGBTQ youth as well.
Yeah, so anytime you're talking with youth, you want to just make sure that you're being very centered on them. I would also not make it just about sexual history taking, trying to establish rapport and talking about other activities as well. I'm trying to remember if any of the Fenway modules specifically address LGBT youth. I think that they do. And some of the youth that you're going to be working with might have other family dynamics or school dynamics that come up. So they might not be out to family members or folks at school. So I'd say for that population, really emphasizing the confidentiality part is even more important. Letting them know you're not going to disclose this to anybody else. You may end up being the only person that they confide in if that's the case. But certainly letting them know that you're here, you're not judging them. And if they're kind of reluctant to discuss practices, maybe letting them know, well, if you told me you were engaging in a particular kind of sex, I might want to do some different testing. So being really clear with them about the rationale for why you're asking this.
Great, thanks, Yvonne. Another question that has just come through is, how do you deal with some challenges? And here the person that asked the question said, how do you deal with red flags? For example, a young person, an 18-year-old who writes that they've had 20 partners. What's the best way to ask and get more information about that, knowing that they have a lot of partners?
Yeah. So in the practice where I work, that is certainly something that has come up a fair number of times. For that person, if they're really young, you might want to do a little bit more discussion with them about if there's some reason that they have a lot of partners. Is this all consensual? Are they maybe engaging in sex work? So trying to figure out what's their level of comfort and if there's some other motivation for that. I don't know if I would necessarily change a ton of other things that I would ask that person, honestly. I would certainly talk to them about prevention. I would certainly talk to them about testing. I would want to see if they're vaccinated, if they're a candidate for PEP or PrEP or contraception. This might be a great person that if you've got a counselor, seeing if they want to talk to a counselor. It could be that this person feels completely comfortable with their sexual practices, but if they let on that, there's some reason I'm doing this and I'm not entirely sure that I am ready to talk about it with you, that might be someone to refer to a therapist. But yeah, if you're having this conversation and you see these red flags, you as a provider make sure that you're doing your end in terms of the clinical visit, but also making sure they've got some kind of resources. So support groups, therapy, counseling, anything else that you could give them, I would certainly want that person to leave with some more resources.
Thanks again, Yvonne, for that pertinent information. And we have a bunch of other questions. I know this is something that comes up in San Francisco at the STD clinic, so we'll go with this one, which is how do you address clients who are engaging in sex work?
Yes, absolutely, that comes up a lot. So what we tend to encounter is a lot of our clients who are engaging in sex work are actually quite well informed. So oftentimes these are folks who are very willing to discuss sexual practices with you. Many of the folks that I work with do report pretty high rates of condom use, or they're coming in because they've self-identified as needing to be on PrEP. So if someone does mention that they're doing sex work, I would certainly use that as a time to get a really comprehensive history, to ask about the specific practices they engage in, if they're using condoms with clients. If they're not, what are some barriers to that? And then making sure that they're getting tested pretty regularly and there's any other interventions you could offer them. There are some clinics. I know in San Francisco we have a clinic, St. James Infirmary, that specifically addresses sex worker health. So sometimes we might refer folks over there. They've also got some support groups. So that can be another place if people need a little extra support. But generally, if a patient is going to disclose that to you, I'd say to put them at ease and say, thanks for letting me know. Is there anything that I need to know about that to support your sexual health? And this might be something that clients are reluctant to tell you because they're concerned about what you're going to do with the information. You know, letting them know you're not going to call law enforcement on them. Letting them know that you're asking this because you want to be able to help them with their sexual health and see if there's anything additional they could be doing to stay safer. But yeah, we certainly see folks engaging in sex work, folks of all genders and orientations, and in general, just having a good conversation with them to let them know that it's a safe place for them to come. They are not going to be stigmatized for disclosing that information, and we'd like to see them on a pretty regular basis to help them stay on top of their sexual health.
Thanks, Yvonne. So here's another question, just wondering, in general, how much time do you allot for sexual history, recognizing that it may be different for different providers, but questions is just pertaining to how much time does it usually take?
Oh, yeah. So this is certainly something that can vary really widely. You might have a patient whose sexual history is pretty brief, and they don't have a lot of concerns about it, and that person might give you a pretty good history in 5 minutes. I've had other people where my sexual history might take a 20-minute conversation to really get a good idea of their history. I'd say being prepared on the first visit for it to be a longer conversation, for sure. I would say minimum, give yourself 5 minutes to at least start the conversation. If you find that you've answered all those questions in 5 minutes, great. But if your setting is more particular to sexual health, or the patient's presenting concern is very specific to sexual health, I would certainly give yourself a little more time. And if the patient has identified as having a sexual health concern, try to bump up the sexual history to a little earlier in the conversation, so that way you can sort of gauge the rest of the time you've got. But yeah, I'd say minimum 5 minutes to introduce the topic and get at least touch on those 5 Ps. But a lot of the time it is going to take a lot longer than that.
Thanks again, Yvonne. We have a couple other questions. So any tips for taking sexual history in older age people, over the age of 65? There was a comment there, sexually active or would like to be, and I'd agree with that. Yes, we definitely do see STDs in older age populations, so any tips on that age would be useful.
Oh yeah, absolutely. So once again, in my practice setting, we see plenty of folks who are in their 60s and older, and this is a time to challenge your judgment or assumption. So if you're working with an older client, don't assume that they aren't sexually active. Don't assume that they only have one sexual partner. I would take this approach the same way that I would take it with any patient, really, and framing it as we ask every patient who comes here the same set of questions. And if they kind of hesitate, you can say, regardless of age, we want to ask these questions. We don't make any assumptions about people's sexual practices, so just a few questions to help me better work with you. And yeah, I've certainly seen patients in their 80s at our STD clinic. So absolutely, there's folks of all ages engaging in sexual practices and getting STDs.
Thanks again, Yvonne. So here's another question, wondering what your thoughts are on any issues dealing with patients who are from different ethnic backgrounds. There's a concern that some of these topics could be sensitive or offensive, or maybe that they're not being translated the same way that how you're phrasing your question. So any thoughts on that arena?
Yeah, this is a hard one, especially if you don't speak the language and you're using a translator. It can be hard to know if these questions are coming across appropriately. Sometimes I might go back and ask the translator to say it in a different way. So if I feel like maybe the question wasn't answered in a way that I was expecting, to say, can I clarify that with you? And so maybe asking the translator directly and then having them ask the patient again. And I would say that the idea that just because someone is of a different cultural background that they're going to be offended by the topic of sex is a little bit of a bias that a lot of us have. So I would want to know about someone's sexual practices, even if they're of a different culture than I am. And once again, acknowledging whether it's to the patient or through a translator, these are some pretty personal questions, but I'm asking you this to be able to help you the best I can, and this is an important part of your health. But yeah, I certainly know there's times I've worked with a telephonic interpreter where they've asked me, they don't know a word for something around sexual health, so we might have to discuss a little bit back and forth and do a little bit of circumlocution. I feel like I've probably done some sexual health education for translators on the phone. But yeah, there are just going to be some times that we're not sure how things are being translated, which is one of the reasons it's important not to use friends or family members for translation and to use a professional interpreter whenever possible. So that way we have folks who have been trained and are affiliated with an organization that has vetted their skills in translation. But you know, I would say if you're feeling uncomfortable, ask yourself, is that your patient's discomfort or is that your discomfort? Because I think a lot of times the discomfort is coming from the provider end.
I couldn't agree with you more, Yvonne, in terms of provider discomfort. It often plays a big role, and so kind of keeping that in check is so important. A couple other questions here. How do you deal, or what's your approach with HIV disclosure or non-disclosure?
Yeah, this is something that comes up, once again, in my setting a lot. And there are some patients who are HIV positive who might not disclose to their partners. And this is a great time to have a conversation about what are some factors that make you disclose to somebody or not. So this is a time for our open-ended questions. This is a time for the patient to let you know about their experience. And you could have someone who's got a really cogent argument for it. I had someone the other day who came in and said he is HIV positive, he's on medicine, he's undetectable. What we know right now is undetectable means untransmittable. And he said that sometimes he has anonymous sex and might not disclose to his partners. And he feels okay about that because he is on medication and undetectable. And I can see that as a patient that many providers would have a hard time working with. So we might be concerned that are we enabling behavior that some patients are, or this patient's partners would be uncomfortable with. So a few things that you can do is, yeah, getting that patient to talk with you a little bit more about what the circumstances are where they don't disclose. And if it seems like they're not thinking about the partner's reaction, that could be a time to have that conversation. Like, how do you think someone would react if they found out about your HIV status and they didn't know before you had sex with them? So once again, using your open-ended questions, trying to get the patient's perspective, and encouraging the patient to think about it from other folks' perspective. But yeah, I can see that as certainly a potentially challenging clinical encounter for a lot of folks.
Thanks again, Yvonne. So a few more questions, and just to folks who are continuing to put questions in, if we run out of time and we don't answer all of the questions, we will send out responses and answers to questions. And there's some questions that are coming in regarding screening and testing and intervals and things like that, which is a little bit beyond the presentation today, which we can answer in our Q&A written out document. So there's a question regarding the relevance of sex toys as the type of sex that they're having. There's wondering, you know, how do sex toys play a role in terms of sexual history taking? Why is that important?
Yeah, so one thing, I'd say this one is kind of controversial. I don't think that we've got a lot of studies that are looking at sex toys in terms of transmission. But it is helpful for us to know what our clients' sexual practices are like. So talking to them just to get a complete picture of what their sexual practices are. It might not be very high risk for things like STD transmission. But it's also nice for you to set the tone with your patient that you're open to having this conversation and you're not necessarily worried about it. But yeah, I don't know of any studies that look at STD transmission from sex toys. So I think it's going to be a little bit controversial. I wouldn't necessarily change my testing procedures for a client who talks about using sex toys. But it is something that could be part of their life, and so just being open to having that conversation I think would be important for us. So it might not inform our practices around testing or other interventions, but it's part of someone's sex life, so we should be open to having the discussion.
Thanks, Yvonne. And I just want to add that there is some data on BV in particular, sex toys transmission between females. So that's the one that I'm aware of off the top of my head. There may be others, but I agree with you that it's just good to let patients feel comfortable that you're willing to talk about all of their sexual practices, which does include sex toy use. So I think there's one or two more questions. Here's one. What's your approach with dealing with somebody who keeps coming back for STD testing and they have revealed in the past that they have some risky sexual behavior? How do you engage in a conversation with them about it without having them become defensive about their sexual behavior?
Yeah, so I would say if someone's got risky sexual behavior and they're coming in regularly for screening, that's actually what I would want to see. So this might be one of those times where the question is the patient uncomfortable with their behavior or is the provider uncomfortable with their behavior? And it can help to check in with the patient and say, is there anything about your sex life that you're concerned about? And maybe it turns out that, yeah, they're not comfortable engaging in the kind of sex that they have been and they want to discuss it. Maybe they want to meet with a counselor or therapist. But honestly, this might be something where the patient is coming in appropriately for screening based on their sexual practices. For example, we recommend that our sexually active men who have sex with men in San Francisco get screened every 3 to 6 months when they're asymptomatic. And we recommend that as an interval because we tend to get pretty accurate STD diagnoses at that interval. So for patients who, yeah, might have risky behavior and they're coming in, I actually see that more as an opportunity to praise them for taking care of their health. So yeah, certainly check in with them, see if they're comfortable with their practices, and if they are, I would encourage that person to keep coming back. If there's things you can recommend, such as considering being on PrEP or getting vaccinations, see if there's things that you can do to support them, but this is certainly a time for us to check in with ourselves. Is this your provider discomfort with your patient's behavior and the patient is totally fine with it? So yeah, doing a little bit of self-examination there before you jump to the assumption that the patient is not comfortable with their practices.
I would agree with you, Yvonne. Thank you for that very useful tip on checking our own biases in terms of interacting with our patients. I think there's one other question. I'm just going to clarify this person's question. The question was how to address when a client is living with HIV and is not on PrEP. I just want to say here that the PrEP is for patients who are not HIV infected, so it's a pre-exposure prevention. And so it seems like we definitely do need to have a training on PrEP and PEP, but that the HIV infected person would be on antiretroviral therapy, hopefully, and maybe that was the issue that they were wondering about. Let me just pull and see if there's any other questions that we should be addressing with right now. I think that most of the other questions we're probably going to address in a Q&A at the end that we send out to everybody. Some of them are kind of beyond sexual history taking, unless there's any that you see, Yvonne, that you want to tackle. Some of them have to do with piercings and mutilation practices, kind of beyond sexual history taking, unless you would like to address them. Oh, Yvonne got disconnected. All right, everyone. Well, thank you so much for being part of our webinar. She may try to come back on the line, but I think that we've almost reached our time. So we will conclude our webinar for today. This will be recorded, and we will address the additional questions that were asked. Some of them were beyond kind of sexual history taking, and so we can respond to those with a Q&A document that will be sent out to everyone who is registered for this webinar. Again, please, everybody, fill out the evaluations that get sent to you. If you want CMEs, you need to fill out the evaluations. And we will let folks know when our next STD expert webinar takes place in the spring, and that should be on vaginitis. And it looks like there's interest in a PEP or PrEP webinar, and we have one planned for 2019 as well. So thank you, everybody, and have a great day.